So people with any of those habits are going to be considered high risk for sleep disorders. Okay, objective number 6, biopsychosocial sleep intervention. What are we going to do? List 5 biopsychosocial interventions for improving sleep hygiene. This is where we'll spend the majority of our time. We can do a lot of things. We can improve their diet. We can add those melatonin-producing foods. We absolutely need to get that HPA axis down, that cortisol level down, improve their stress management. We need to get them out and moving, and I'll give you the research on that. Nature nurture is another great way to do that. They need adequate amounts of sunlight during the day. Sunlight does dictate, and light in general dictates sleep. That's why people who work in, let's say, ICU or are in ICU tend to have worse outcomes if they don't get critical exposure to light. So nature nurture is very important. And then finally, sleep hygiene and habits. These are all the things that we teach as a part of medical therapeutic yoga, because MTY really throws its arms around a whole lot of integrative medicine and makes it very easy for us to implement lifestyle medicine practice. Okay, so first, I want you to complete the sleep screens, or at least screen for high-risk behavioral activities. A lot of times that's what I'm doing. I'm asking them about all those high-risk behaviors for sleep. And if they have those, of course, if they have snoring issues or they have daytime sleepiness, that's a referral for a sleep study. Otherwise, I'm going to try and intervene and improve their sleep quality. Consider your stage of change. When you are talking to them, you don't want to talk down to them, talk over their head. You want to guide them and meet them where they are. So if they don't know how important sleep hygiene is, then start there. Start there with a few statistics about how important sleep hygiene is and good quality sleep is. If they know that sleep is a problem, then start there. If they're sleeping well, but they tend to fall off the wagon and maybe they're eating late or watching TV, in from bed at night, then identify those problems. So what I'm saying is just meet them where they are. Circle 2 to 3 things that they want to work on. Rate their self-efficacy, which is on a scale of 0 to 10. How confident do you think you can follow through with these recommendations? You want your patients to answer to 7 or above. If they answer below a 7, then you're going to have to stop and say, okay, what are some of the difficulties in implementing, these changes? And what can I do to help you implement these changes? You also want to start with a success. So if they have blackout drapes, great, awesome. If they have a little noise machine they use, great, awesome. If they've taken the TV out of their room, fantastic. Applaud what they're doing correctly, and then talk about the 2 changes or so that you would like to make, set a date, and then ask them what kind of support they need to make that change. We want to be around 7 or 8 hours of sleep. Now, obviously, you can go up to 9. Anything really 9 and over is going to have the same negative ramifications as under 6 and under. So we want to shoot between 7 to 8, maybe a touch over 8, depending on what you've been doing lately. If maybe you are jet lagged or you've pulled a 12-hour day, well, you might sleep 9 hours occasionally, but it shouldn't be all the time. So less than 5 to 6 increases cardiovascular disease risk, and greater than 8 to 9 increases cardiovascular disease risk. You want to be in bed by 10 p.m. You want them to power down all their devices ahead of time, or if they cannot do that, which is common in our telecommuting world now, and it can be very difficult to power down, although that's the goal, then at least get them to turn amber light on. And that's an automatic setting on anybody's phone. You just go to that display, or light display setting, and then it'll allow you to set a time. So mine is set for about 7 o'clock in the evening until morning. That amber light is going to be on and the phone is going to be dark. And that helps a great deal. A couple of other things I want to mention is that the time of day for exercise It used to be, oh, don't go out for a run in the evening or whatnot. We can see that that might increase kind of HPA axis activation. For some people, it's very relaxing. So we don't know how everyone responds to exercise, but what we do know is exercise is critical. So instead of worrying about the time of day that you're exercising, just get them to exercise. Okay. In the literature, that time of day for exercise is not found to be significant. But we do know that exercise increases slow wave sleep and total sleep time, and it decreases sleep onset. So just get them out there and get them moving. For sleep intervention, the outcome measures that we're going to use are the PSQI and the ESS. For general sleep quality, very generic screen, and then for daytime sleepiness. Your intervention is going to be assess the general risk, ask those general questions that I gave you, go through sleep hygiene, which we have gone over, we're going to continue to go over a little bit more, get them to normalize their physical activity. Now you're finishing modules 1 through 4 now, but you'll notice there's 2 big elements that were left out of modules 1 through 4. And that was physical activity prescription and environmental influences. So after you finish this, if you're doing the lifestyle medicine certificate, you're going to go and do 2 more hours of 2 courses, so 4 hours total. 1, so that you're up to date on all the physical activity guidelines. That will be your exercise prescription. And then 2, environmental influences. Okay, just throwing that in there to let you know you're finishing modules 1 through 4. Congratulations, fantastic. You've got a really good basis for using lifestyle medicine in clinical practice. And then the last 2 modules are going to help you polish everything off. Also discuss positioning and sleep. Now this is where as therapists and docs, we're used to doing that. If someone has a shoulder pain, hip pain, or maybe it's a neurological condition, neurodegenerative condition, we're going to get in there and talk about transfer safely. We're going to get in there and talk about positioning and make sure they're comfortable, and address bed mobility issues as well. Okay, and then the last thing is refer, especially if there is a suspected sleep apnea or psychiatric issue. Okay, so how can we influence melatonin levels? The elderly who are not exposed to daylight, sunlight, are going to have major issues with falling asleep in the evening. So they need to actually be exposed to natural daytime exposure light. In the absence of that, let's just say you live in Alaska, for example, then you're going to need to be exposed to that blue light. And so you can get a blue light machine. Having those in ICU and adult care facilities makes a critical difference in outcomes on people. There are several studies that obviously support the claims that I'm making now. So we can be assured that blue light exposure is critical during the day. We want to take that away in the evening. That if you do supplement, as you see here, if you do supplement, that the toxicity, and this was in a randomized double-blind clinical trial, that looking at toxicology of chronic melatonin treatment, is that it has remarkably low toxicity and is without significant side effects if used at less than 10 milligrams per day. Less than 10 milligrams per day. However, the literature does recommend 1 to 3 milligrams. And if I'm discussing a patient's independent decision to supplement with melatonin, I'm not prescribing supplementation of melatonin, I share the evidence base with them, and then they can determine whether or not that resource is something that they would like to utilize. Also discussing with the pharmacist or their physician if there's any other drug interaction that they need to be aware of. When I am discussing that possibility with patients, then I will recommend they take the least amount possible to see if it gets the desired effect for them, which would be 1 milligram. 1 milligram, not 10 milligrams. So start low. Typical starting point is 1 to 3 milligrams about 2 hours before bed, but you can also do as little as 30 minutes before bed. You can also eat foods with tryptophan that are melatonin producing, as I already mentioned. And you can orally intake tryptophan, like 5-HTP or B6. Nutritional timing is also of importance. This is an emerging area of scientific evidence. So this is what we have available to us now. We don't want to be eating simple carbohydrates less than an hour before bedtime, although the consumption of complex carbohydrates can facilitate sleep. You want to avoid consuming sugar-sweetened beverages at dinner time. It's associated with poor sleep quality. Increase your protein, especially a fatty fish intake in the evening. Increase your plant antioxidant intake. Increase the foods that are going to be melatonin producing. Also, interestingly, skipping breakfast and irregular eating patterns are associated with poor sleep quality. And maybe because that just impacts the rhythm of what happens during the day, your circadian rhythm. So low intake of veggies, high intake of simple carbohydrates are associated with poor sleep quality. And this was among middle-aged female Japanese workers from a 2014 study. There are several studies that I use, too many to actually cite. I'll count them for you though. Let's see, 1, 2, 3, 4, 5, 6, 7, 8. 8 studies support this particular slide. Iron deficiency can also interrupt sleep. Low vitamin D levels can interrupt sleep. That's why consuming vitamin D can assist with improving sleep. Vitamin B12 can enhance the phase response of circadian melatonin rhythm, but you may want to take B12 early in the day, not in the evening. And finally, another study on vitamin D, so that's important, and then tart cherries as an antioxidant, anti-inflammatory, and being melatonin producing.